totally unnecessary. I love this thing. I can't help but use it. It has a very slow decay, so people get to finish their conversations. Still going. It's beautiful. Travels well. Welcome to the Levitt Distinguished Lecture, sponsored by the Department of Family Medicine. Some of you veterans know that we do several of these a year. Louis Levitt was born in 1896, and he went to vet school, and then he went to medical school and became a general practitioner in the city of Denver for 40 years. He practiced until 1967, and when he died in 1976, he left the Department of Family Medicine a small endowment, stipulating that we use it to bring interesting, provocative, distinguished speakers to town to educate you and edify you and inspire you and challenge you and otherwise make your lives better. And we have been doing that for longer than I've been here. We've had almost 75 Levitt speakers by now. And today, I'm proud to present to you one of the best. You're about to have a good time for the next hour. Stephen Hwang is today's distinguished Levitt speaker. And I want to take just a moment, just a brief moment, to give you just the slightest orientation to who he is. He'll tell you more. Stephen was born in California. He lives in Canada, lives in Toronto now. He's in the envious position of being binational and having two passports, which I wish I had right now. He completed his medical training. He got an MD at Johns Hopkins, and he got a master's in public health from Harvard School of Public Health. And he had a distinguished career as a clinician and a leader within an academic institution. In fact, he was the chief of the Division of General Internal Medicine at the University of Toronto until he slowly gave that position up so that he could devote himself full time to being the director of, they now call it MAP, as you can see here, MAP, Center for Urban Health Solutions. This is a research shop at the University of Toronto and in St. Michael's Hospital in Toronto, which basically studies comprehensive health solutions for the urban underserved. He studies these things. He does that in a rigorous way. And I have enjoyed the last almost 24 hours talking about how they solve some of the stickiest problems for and with the urban underserved, and listening to his ideas about how we can proceed as we trick out a program here for a much more comprehensive and focused effort toward the urban underserved.
So thanks for being here. I'm going to talk to you about creating urban health solutions, promises, and perils. So I thought I'd tell you a little bit about how I came to do the work that I do and kind of what was one of the seminal moments in my development in this field. So this is a picture of a church in Cambridge, Massachusetts, where I went to undergraduate. And at the time, I was a freshman in university, had essentially every opportunity open before me, great classes, great classmates, food provided in abundance, a warm roof over my head, friends, social activities, and a future ahead that looked pretty good. And what I noticed was that walking around the streets of the town were people who were homeless, carrying everything that they had in the backpacks on their back. And this was back in the 1980s when homelessness was first becoming a noticeable problem in cities across America. And so a number of students at the university, not me, came up with the idea of opening a student-run shelter in the basement of this church. So every night, student volunteers would come in and welcome about 50 people who would line up at the door to the basement. They would lie down there would be mats provided, just little thin mats on the floor. People would sleep on the mats, and then in the morning, we would provide them a meager breakfast of stale donuts and bagels that had been donated by businesses, and then we would send them on their way. And one of my jobs was to essentially stay overnight, check people in, stay overnight, and then help clean up in the morning. And I want to tell you a story about something that happened to me one morning when I was cleaning up at the shelter. And the story involves a mop and bucket that looked almost exactly like this. So at the time, I was an eager pre-med student, and like all pre-med students, or many pre-med students, I'd spent most of my summers doing research jobs, hoping to increase my chances of getting into medical school. So I had never worked an honest job that required me to like mop a floor, like in a McDonald's, a 7-Eleven or something like that. So one of my jobs in the morning was to mop the floor of the basement of the church. And so I had a bucket and a mop like this, and I was mopping the floor in a rather ineffectual manner when one of the men who I'd gotten to know from volunteering at the shelter came up to me. His name was Pat, and he was, I thought he was really old at the time, but in retrospect, I think he was probably about 50 years old. He spoke in a thick Irish brogue, a Bostonian Irish brogue, so I'm not going to try to imitate it, but you can just imagine. He and his wife slept at this shelter every night. And at the time, the reason they slept at this particular shelter was that all shelters in Boston at the time were either male or female only. And so the only shelter that he and his wife could sleep in and not be separated was this shelter. So Pat came up to me and said to me, "Son, you're not mopping that floor right." He said, "I used to be in the Navy, and we used to have to mop the deck of the aircraft carrier regularly. And so what they taught us to do was to lay out a grid pattern on the floor, and then to take the bucket, rinse the mop, do a back and forth direct motion," and he showed me how to do it in one square of the floor. And he said, "Then you rinse the mop, and then you do the next square." And so he handed the mop back to me, and with a wink and a smile, he said, "There, now you know how to do it." And the reason I tell this story is for two reasons. One is that, first of all, what I realized was how incredibly wrong it was that there I was, that I had all this opportunity and every kind of blessing that I could wish for, and right next to me was passing every day people who had nothing. And that struck me as incredibly wrong and also contrary to my understanding of the biblical call for justice. The second thing that I learned in the shelter, and the reason that I'm showing you this bucket, is that what I learned was that I had encountered someone who was experiencing homelessness not as the other, not as the homeless or homeless people or as some abstraction, but as a human being worthy of dignity and respect, and who treated me with kindness and respect as well. And I've always remembered and have often shared this story with people and said that, I think that it's a reminder that when we give, we typically receive more than we give in return. And so, after this experience, I went on and did my medical training, and in general internal medicine, and I wanted to work after I finished my training, serving an underserved population, and I got a job with Boston Healthcare for the Homeless program. So this is a picture from many years ago at a large shelter in Boston called Pine Street Inn. It's got about 500 beds, and there is a nursing clinic in the shelter. And I just want to emphasize it's a nursing clinic. And many doctors who have come through the Boston Healthcare for the Homeless program have learned a lot from the nurses at Pine Street Inn, because what they do is they have a clinic, and you can see that the men come in, and the first thing that they're asked is not, what are your symptoms? What medical conditions do you have? What prescription can I give you? But they're asked if they would like to take their shoes and socks off and soak their feet in a warm, soapy solution to clean off their feet, to have them dried off, and to be offered the chance to get a clean pair of socks. And then, as you can see, the nurse is also checking the person out and helping them with whatever their need might be. But I think that what the lesson I learned from these nurses and from working there was the need to meet people where they are and to not bring our agenda to solve the problems that we as professionals like to diagnose and treat, but to meet them as human beings and to just listen to them and what they want to say to us. So after I worked at Boston Healthcare for the Homeless for 4 years, I was seeking an academic position and found one at St. Michael's Hospital. So St. Michael's Hospital is an academic teaching hospital in Toronto. It was founded about 150 years ago by the Sisters of St. Joseph to serve the poor and the sick of Toronto, back before there was healthcare, universal healthcare in Canada for everyone. And this hospital, by virtue of its location in downtown Toronto, serves people of every walk of life and from every background. It takes care of people who are homeless, people who work in the sex trade, people who are addicted. It serves CEOs from banks and corporations that work on our equivalent of Wall Street, Bay Street, just down the block. So it serves really people from all walks of life. But St. Michael's Hospital has always had in its mission and in its DNA to serve those who are poor and marginalized in society. What St. Michael's Hospital at the time had also realized was that it needed to be, in addition to being an organization that provided clinical care, health care for people who were disadvantaged, that it also wanted to make that an academically productive and academically vigorous program. And so they started looking for people, and they found me, and so I ended up with a position at St. Michael's Hospital. And over the course of the last 23 years that I've been there, the hospital and the research program has grown and developed tremendously. And so, the problem of homelessness is one that's very visible on the streets of Toronto, and this is one of the population groups that we serve at our hospital. We serve a neighborhood, this one's called Regent Park, that has a high concentration of immigrant families, people whose first language is not English and often who speak very limited English, who are raising their children and families in very difficult circumstances. And whereas you can see in many cases the housing is in substandard condition. And so what began as a very small endeavor has grown into, as has been mentioned, the MAP Center for Urban Health Solutions. And I'm going to tell you a bit about who we are and what we do. So first of all, the first question that everyone always asks, and it's a great conversation starter for me, is what does MAP stand for? So MAP is not an acronym. MAP is essentially a name that conveys the fact that we want to chart the way to creating the world's healthiest city, that we are showing the way. And so this is our pitch. And so I'll just say, I think you've all been to talks where the speaker is there to kind of give you a sales pitch and tell you how wonderful their product is. So allow me to indulge in just this one slide, but I do want to acknowledge that this is what we aspire to be. This is not what we have fully accomplished, but we are a world-leading research center dedicated to creating a healthier future for all. Our scientists tackle complex urban health issues with a focus on scalable solutions that address social determinants of health and reduce health inequities. And we seek to achieve real-world impact through intersectoral partnerships and with meaningful engagement with community members, policymakers, and providers. So, having said that, these are some of the faces of scientists at MAP. And so I think that just to give you a sense of the diversity of the clinical backgrounds or the disciplines that they come from, we have here someone who is a general internist with a focus on addictions and HIV, a nurse, PhD nurse researcher who focuses on prevention of HIV transmission in men who have sex with men, an endocrinologist who focuses on how the built environment affects the risk for obesity and diabetes. We have many family medicine physicians who focus on primary care delivery, cancer screening in immigrant populations. How can we linking the social screening for the social determinants of health and treating social needs within the primary care setting, and a vast array of other areas that I'll get into in just a minute. So our main research pillars, so the 5 areas that we have the greatest strength in, are in the area of interrupting chronic homelessness, and that's an area that I do research in. And if you're interested in that, I'm talking about that later this afternoon at 2 p.m. We are working on removing barriers to essential medicines. So just to explain that, in Canada we have universal health insurance. We don't have universal insurance for prescription medications. But that's what we're working on now at our center, and we're doing research to try to lay the groundwork for that policy shift. We want to disrupt the opioid crisis, which has swept across cities across North America, including Toronto, and seeking innovative solutions to try to interrupt that crisis. We believe in intervening early for a lifetime of health for children, and early life interventions is a growing focus of the work that we do. And lastly, we seek to advance Indigenous health in urban homelands. We have a very large Indigenous population in Toronto and across Canada, and it's an area that is deserving of priority focus. We also have other areas of research strength. We have scientists who are experts in the prevention and treatment of HIV and sexually transmitted and bloodborne infections, and really driving towards the goal of eliminating HIV transmission in Canada. We have researchers who are focused on primary care systems and how they can better serve disadvantaged populations. We have researchers focused on prisoner health, intimate partner violence, food security, and the built environment and health as well. So this is just a kind of a high-level overview of the topics that we do research in. And our purpose is to tangibly improve health through scalable solutions. So yes, we do research that is theoretical and epidemiological and descriptive in nature. We look at those classic things that are very much like curiosity-driven research, but we're very much focused now on how can we make a difference? How can we have a visible impact, a concrete, measurable impact on our city and on the health of populations? And we do that by a series of approaches, and so this is just kind of the way we conceptualize the work that we do. There are early pilot studies that sometimes we do and sometimes others do to try to develop new approaches. But often what we do is what we have is pilot studies that have been done by others or ourselves, and they're very promising, but we don't have the evidence yet as to whether or not they're effective. And so what we view as one of our fortes is moving from that second point to the third point, to do the rigorous research and evaluation to determine if that promising intervention that looks really good and sounds really good is really effective, and can it be regarded as a proven solution. And lastly, and this is something that often researchers fail to follow through on, is we do the research, we publish the paper, and we move on to our next grant and publication. But what we view as part and parcel of our work is taking those proven solutions and scaling them up and ensuring that they get enacted in our city, across our province, and hopefully in cities across Canada and around the world. And that's something that I think is really important to start with and to think about. And I'll talk about that later in my talk. So over the years, our research program has grown and flourished. And although we're very proud of it, although it's a very modest building compared to the beautiful facilities here at the University of Colorado, this is our research building connected to our old and somewhat decrepit hospital building by a tunnel, by an overhead bridge that symbolizes the connection between research and clinical care. And we view that as a really important connection to cultivate. Having said that, the problems in our city have not been solved. And there have been changes in our city that go on, some for the good, some for the bad. And so we've seen urban development in our city, and this is a public housing project called Regent Park. It's been redeveloped over the years into a mixed income housing development. And so this is actually a view of what Regent Park looks like now. It's a much healthier, more thriving community, and it still has a focus on affordable housing for low-income people, but it also is now a growing part of our city, as opposed to being kind of a set-aside cloister of low-income housing. So that's positive and evidence of change for the good. But at the same time, we've been, in some ways, the victims of the success of our city. So we have a very affluent, booming city. Much as I understand, Denver is doing very well. And so if you have $700,000 in Toronto and want to plunk it down right now, you can have your choice of beautiful new condos overlooking the lake with every amenity that you could possibly desire. But if you are working in a minimum wage job, or if you're on welfare or disability, and what you can afford is $550 a month, which is kind of typical in our city, you can live in this basement that has been hived off into a couple of rooms, and which, as you can just imagine from this photo, which actually shows actually this is a real photo of a place where a young person, a young adult who had moved out of homelessness had moved into. So yes, they're no longer homeless, but they're now living in a filthy basement with almost no light in a house. We continue to face problems in our city that have not been solved by research, and the number of homeless people in our city has gone up in the last few years. It has not gone down. So more about that in a minute in terms of what does this mean for trying to work towards urban health solutions. I was told I need to have 3 learning objectives for this talk, and I'm putting them up here because actually I do want to address these 3 learning objectives. So first of all, I want to have us identify some key challenges in urban health and health equity initiatives that may help inform your efforts here in Denver and Aurora. Secondly, I want to discuss and recognize the advantages and disadvantages of various approaches to interventions to try to increase health equity, and to think about how you might apply this to your practice and research. And thirdly, I do want to consider the value of generalism and interdisciplinarity in urban health action and research. So, the first key challenge is why. And the slide has no other words because I just want to talk about this. You've probably heard about a book called Start With Why. That it's really important to think about why are we doing the work that we're doing. And in urban health research and in health equity research, I think that's extremely important, that we stop and think, why are we doing this work? And I think that you all know, or you've seen this, that sometimes people do this work for a variety of reasons. Sometimes they do this work because it's a great academic pathway. It's great they can get grants and publications, and they're building their careers and their success by doing this kind of work. There are people who constantly seek the limelight, who want the media attention, who want to be seen as that savior that is solving the problems and doing good. And so I think that we have to stop and think, so if we really want to do this work, we have to ask ourselves, why is it important to do and why are we doing it? And I think that's fundamentally a question of values and of beliefs about what is right and what is wrong and what is good fundamentally. And that's a philosophical, ethical, moral, and spiritual question. It is not a scientific question, I would argue. And that's why I think we really need to start there, because if we really believe that this is a matter of justice, this is a matter of human dignity, this is a matter of doing what's right, then, and this is not about us. This is not about how it makes us feel or how successful we can be doing the work, then that's the right place to start. But I think we have to take a hard look at ourselves and think about why do we want to do this work. The second thing that I think is a key challenge in doing this work is the question of long-term commitment. So I think that if you want to do this kind of work the right way, you have to be willing to say you have to be able to say you're in it for the long haul. Because, first of all, if you're doing it for the right reasons, this is not something that you're just going to do until you've gotten that promotion or you've gotten that job or you've finished that project. You're doing it because it's the right thing to do, and you're going to keep doing it as long as the problems exist. And I think it's fair to say that the problems are going to exist for as long as we're alive, and so we need to be willing to make that long-term commitment. The other reason it's really important is that the people who are experiencing marginalization and disadvantage have often seen a steady stream of people parachuting in and then helicoptering out of their communities and basically kind of not really being in it for the long term, and they're tired of that, and they recognize long-term commitment and someone who's in it versus someone who's in it for the short term. And if you really make a difference in this work, you really have to be willing to say, I'm in it for the long term, and your institution has to be willing to be in it for the long term. So I guess that you really have to think about it. Is this a flash in the pan, or is this something that is really going to go on, be the work for the next decades? The third key challenge that I think is really important, and this is not a surprise to any of you, is the need to have genuine partnerships with your community. And so I'm not here to tell you about how to do that in your community, and by no means am I a master of doing this, but I just want to reflect on some of the things I've learned over the course of my work. And one is that, first of all, there are many different issues in the community, and that raises the question of so which community are you talking about? So if you're trying to do work focused on, let's say, food insecurity, that's one issue. If you're doing work on the transmission of Hep C among people who use injection drugs, that's another issue in your community. The communities of people who are concerned about and engaged in those issues are going to be quite different. There may be some overlap from issue to issue or from project to project, but you have to realize that it may require multiple levels of engagements with multiple different groups within your community, because there's not just one kind of unitary community that you can engage with. The second thing is who represents the community. So this is a real challenge, because in most cases there is no leader of the community. This is not a situation where you can say, oh, this person represents everyone in this neighborhood. And so you have to realize that unlike, at least in the academic world, there are recognized leaders who, I guess, have some legitimacy in terms of their representation of their group or their organization. In the community, sometimes it's not that clear, and you have to negotiate the complexities of that and the fact that there may be competing viewpoints and conflict within the community. And the person that you think is the great representative of the community may be viewed with suspicion by other groups within the community. So the third issue, and I think this is really important, is the need for true power sharing and resource sharing if you're going to engage in this kind of work. And just recognizing the fact that we operate from a position of power and privilege. And so I think it's fair to say that, even though you may not feel this in the room if you're like a student, and we were discussing this earlier today, if you're a medical student, you may say, man, I'm like the least powerful person in the room, I have no power. But actually, you are a very privileged, powerful person, and we are all in very positions of privilege compared to many of the people in the community we're working with. And let me put it this way, if everything's going smoothly and there's no conflict, you're not doing things right. Because if you're really trying to share power with the community, and if you're really sharing resources with the community, and it's not like, I'm going to toss you a few tidbits and scraps that I can spare, there's going to be conflict. And that is actually perhaps a sign of a healthier relationship than one in which you say, oh, yeah, we work with the community and they're just happy with whatever we do. So I think that that's a really important point to keep in mind. I think you've probably heard about the value of engaging people with lived experience in your work. And I think that that's a work in progress for all of us. All I can say is that it's very important to do that for the long haul. So I've done it for projects, but then when the project came to an end, the engagement came to an end. And I think it's really important to develop infrastructures and I guess a commitment to a long-term valuing of people with lived experience and recognizing that monetarily as well. And lastly, there's a challenge here, which is that there is a value to scientific and professional expertise. So there's a reason we don't turn the health system over to Gwyneth Paltrow. So I think that, it's really important to realize that we bring something to the table as well. We bring our scientific and professional expertise and training, and that's of great value to try to address the questions that people with lived experience bring to the table. They have expertise of great value as well, but we have to learn to, I think, mutually respect and build upon that expertise, which is often a very different types qualitatively. One other thing, this is the second point about what level or what approaches to intervention are we going to take? And this is a significant question to ask. So there's often a characterization of micro, meso, and macro level interventions. So micro level is intervening at the level of individuals and families. Meso level at the level of communities and service systems. And the macro level is really those structural forces that underlie many of the issues that we address. And so this is one of those diagrams so usually I have very little patience for diagrams like this, but I'm going to show you this one because actually I think it is useful. It's from the WHO Commission on Social Determinants of Health. And essentially what they have done is they've shown the social determinants of health in two large categories. On the left, you can see they've set up the structural determinants of the social determinants of health, which are things like macroeconomic policies, social policies, the labor market, public policies, culture and society. And that affects social class, education, occupation, income, socioeconomic position. And that in turn affects what they classify as the intermediary determinants of the social determinants of health. These are things that you can measure for individuals, like their living conditions, their working conditions, their behaviors, their psychosocial factors. And those have an impact on equity and health and well-being. And so I think the reason I've put this slide up is that we often put an inordinate focus when we talk about the social determinants of health on the intermediary determinants on the right. Those are the things that we see as individual characteristics in our patients, in our clients, in the population, that we say, oh, we can do something about that because we can change how this person behaves, or we can give this person a program. I think that sometimes we may be missing the boat because we're overly focused on the level of the individual. And so this picture is an illustration of that. So this is a picture of what are called breaker boys, Pennsylvania coal mines, photographed by a famous photographer named Lewis Hwang in 1911. So these boys had the job of taking the rocks that had been taken out of the coal mines and breaking them apart to separate the coal from the shale rock that it was embedded in. And so let me just suggest that if we were to go back in time, not that long ago, 110 years, I realize it seems like a long time, but that's really a blink of an eye. If we were to go back 110 years in time, we could say, you know what we should do is we should do a research study to investigate, the physical and mental health of breaker boys, and we can measure their lung function, see if it's affected by their exposure to coal dust. And they seem to have really poor physical and mental health. We should set up a program to deliver health care for breaker boys, and we should make sure that there's an emergency department nearby, so if they're injured, that they can get health care immediately. But if you look at the photo and if you think about it, what's really needed is someone to step back and say, this is not right. We need to change the law of the land. We need to change the way we do things so that kids aren't doing this work in the coal mines. And so I think that sometimes we suffer from a problem as healthcare providers, typified by the saying, all you have is a hammer, everything looks like a nail. Many of us are healthcare providers, and we tend to look at health disparities from a healthcare perspective. And we think, how can we solve this problem with better healthcare? And when you look at the social determinants of health, what that results in is two things. First of all, because if we're kind of entrained in empiric research and if we're a researcher, we focus on these factors because they're eminently studyable and can be intervened on at the individual level. So we can say, hey, look, we can have a counseling program and provide CBT for this population of depressed people. Or we can look at the correlation between socioeconomic status and access to treatment for disease X. And so because it's easy to do that kind of research, we do that research. And secondly, because we're healthcare providers, because we've got a hammer, we think this is the nail that we should start pounding on. And so I'm not here to argue that doing that kind of work is not important or good. And in fact, I do that kind of work. But I think it's really a potential error to focus on this and to not look upstream at the context, the political, economic, and social context that in many cases is driving the problems that we're trying to deal with. And I think this cartoon really kind of speaks to that issue. So I'm not going to read the caption, you can all read it, but I think that it's just an example of how sometimes we look at a problem and we don't really see the root cause of the problem. The next question in terms of approaches to intervention that I think really needs to be addressed is scalability. So I think we need to start with the end in mind. If your project, if your program, if your enterprise is going to be is successful, what's going to happen after that? Is it going to become a boutique project that everyone in your community knows about, but which can't be expanded or scaled up because it costs it costs so much money that everyone looks at it and says, we can't possibly do that because we don't have $100 million. Is it going to, or do you have a strategy for how you're going to broaden your impact by starting with the idea of, if this works, how is it going to have broader impact in other cities, other communities, and other states and around the world? And really thinking about that before you start out on an enterprise. And lastly, in terms of approaches to intervention, I think we should think about, as scientists and as professionals, what is our role as advocates? I realize that sometimes people view that word as a bad word that we should shy away from. And in fact, at least in my world as a researcher, that's kind of like the kiss of death if someone says, oh, they're just an advocate. I think that we need to think carefully about this because, first of all, yes, one of the advantages that we have is that we bring scientific methods and evidence to the table, and we're willing to apply those methods and say, if this intervention or this program or if this policy does not have the intended consequences or the desired consequences, results, maybe we should stop doing it and do something else. And we have to be open to that possibility. And that openness is an incredible benefit to the work that we do and to the groups, the communities that we work with. But at the same time, we also recognize that we have an enormous ability to advocate for those who have less power and influence and voice than we do. And also I think we should think about, do we have the ability to elevate those communities and individuals so that they have a voice that they can speak with too. But that we should really realize that as professionals and as scientists, that we can speak out with authority on issues that we may not necessarily have done a research study on, that we may not be able to prove empirically, but which may indeed be true and which needs to be said by someone with our authority. And so lastly, I just want to mention, because this is a family medicine lecture, and because I am, like you, a generalist, the value of generalism in this kind of work. So the first thing that we as generalists is we are attuned to context. So we don't take a problem and say, oh, we're just going to look at this tiny little thing and we're going to just look at, if X causes Y and forget about everything else. We're open to, in fact, context is everything in the work that we do. And what better example of that than when you see a patient. The patient, as it's written on the walls of the Department of Family Medicine here, it's more important to know the person who has the disease than to know the disease that the person has. And that's all about context and knowing the person. And that's something that we bring as generalists to the problem of health inequities and health disparities. The second thing that we bring is the ability to have focused expertise, but to keep the big picture in mind. And again, so just to use myself as an example, I have a focused area of research on homelessness, but even though I do have that focus, I try to not lose sight of the big picture, which is that it's not about homelessness, it's about affordable housing and about the effects of housing on people's health, and which has a broader impact on communities and populations far beyond the relatively small group of people who are literally homeless. The third thing that we as generalists bring is humility. So, we are not the world's expert on anything. We are interested in everything. We are curious and engaged, but we can't say, I'm the world's expert on, cerumen in the left ear or something like that. So we by virtue of that generalism and that fact that we're not an expert in just one tiny little area, we have to cultivate the virtue of humility and realizing that there are others who have expertise that can help us do our work. And so that's an important thing when working with communities and when doing this kind of work. And realizing that as generalists, that we work with people who bring completely different perspectives and skills to the problems that we're trying to address, and recognizing the value of those perspectives. And so I'm going to close with this image. So this is a picture of a city in China on the Yangtze River. And one day, this city woke up, and the city had turned, I don't know if you can see it with the lighting, the river had turned this sickly blood red color. And so I use this as a metaphor because I love metaphors. So, if you were a healthcare provider or a health professional in this city, you might say, look, we really need to find out what is the contaminant what is causing the water to turn red? And, we've had people who are touching the water or drinking the water who've gotten sick, and we need to mobilize to provide health care for those individuals. That would be a very worthy thing to do, and that's very important work to do. But I think the picture really kind of helps you quite readily realize where is the problem. The problem is upstream, right? The problem is the factory that has bribed the government official that is dumping toxins into the river. And until you address that broader political issue, that you're never going to solve the problem by helping people in the city. This is not to say that we should not be helping the poor people that have come in contact with the water, but at the same time we do that work, we have to think upstream. And so that's the end of my slides, and if you're interested in learning more about our center, that's our website. Thank you very much.